end of my 20-minute talk, I'll be able to brainwash every one of you here that every early triple negative and HER2 positive breast cancer patient must get neoadjuvant therapy prior to surgery. So that's my goal for the next 20 minutes, and I hope I'll be able to convince all of you. So these are just some of my disclosures. So I work in HKL, one of the biggest centers for oncology care. We cover 6 states. I think some of you here may know that our patients come from all over. We do visitings in 6 different hospitals. Our patients are mostly not seen because our oncology services are still very sparse. But nevertheless, I don't think it stops us from providing at least above average care for our average patients. So these are some of my disclosures. And if we talk about breast cancer, it is a well-known fact that the proportion of patients with young breast cancer is far higher in the Asian population compared to Westerners. So I'm sure all of you are seeing patients every week who are in their 20s, in their 30s, in their 40s. So the proportion of patients who are young, who are presenting with breast cancer in Asia is actually far higher than Western countries. It is a very Eastern problem, actually. For whatever reason, I don't know, but it is a real problem. Breast cancer in pregnancy, breast cancers in young women. So when we were in the 1920s, breast cancer was very easy to manage. Until the 1970s, all that we needed to know was morphology. Every breast cancer was treated the same way. In the 1980s, one of the most remarkable findings in oncology was the fact that estrogen receptor expression, makes a big difference in prognosis, in outcome, in treatment, in everything. So an ER-positive breast cancer patient is totally different from a triple negative. It's almost like a different disease entity altogether. So in head and neck, it's like saying oropharynx versus hypopharynx, totally different. And when we came into the era of the 1990s, we saw HER2 coming into the picture. And of course, again, that told us how these patients behave so differently compared to the hormone positive and the triple negative patients. And of course, in this day and age, we're talking about next generation sequencing. So I know for most of us who work in the government side, you may think that this is something that is not done often. But I must say in the field of oncology, NGS testing and genetic testing is fairly routine, depending on the place where you work. Molecular subtypes of breast cancer has become very complex. It's no longer just ER and PR and HER2. You will see that subtyping is extremely important. With the luminal A's having the best prognosis, these are patients who have ER and PR positivity, HER2 which is negative, and Ki-67 being low. With the same makeup, if you have a high Ki-67, you become a luminal B patient. If your HER2 is positive, you fall into the HER2 positive group. And of course, with the triple negative subtype, you are in a totally different group. So this is a very simplified subtyping of breast cancers. The difference is in terms of the Ki-67, the positivity of ER and HER2. So I must say that this is a very simplified table, because in this day and age, we're looking into this now, whereby luminal A's can also have a HER2 subtype. You can also have a basal-like subtype within a luminal A. So it has become very much more complicated, but I will leave the complexity to the oncologist to decide what to do with them. Okay, so in terms of prognosis, in terms of outcomes, in terms of how we treat them, everything is different. So if a breast cancer patient does well with no treatment itself, patient went for traditional treatment, meditates, does yoga, runs every day, and has good outcome, it's nothing to do with all that. It's just possibly their molecular subtype is our prognosis. Okay, so breast cancer subtypes in general, if we simplify it, the triple negative breast cancer patients have the worst prognosis in general. And unfortunately, it's also the young patients who tend to have triple negative breast cancer. So in this day and age, every triple negative breast cancer patient must have genetic testing for BRCA testing. I will talk about how it's available in the government services. Very much available. There are some limitations, but limitations which can be overcome. I think in government side, we are really good at that. We know how to overcome almost every limitation that is available. I mean, we are trained for that. So anyway, triple negative breast cancer has the worst prognosis. The luminal A's have the best prognosis. And when we talk about prognosis based on subtype, this blue line, which is far high up on the graph, are the luminal A's. Luminal A's are the ER-PR strong positive, HER2 being negative, Ki-67 low. So we are trying to get our pathologist colleagues to report Ki-67 as a standard of care. So some of you all may be working in centers where Ki-67 automatically appears in your initial breast biopsy, but I think it's work in progress. We've actually engaged with the head of service of pathology, and I see that coming in the near future. When we talk about HER2 positive patients, irrespective of what treatment you had, naturally your prognosis is not as good. So why is it that neoadjuvant therapy is actually important in early breast cancers? So we all know that in the past, early breast cancers, as long as it's operable, patients will have surgery upfront. but this treatment the whole paradigm has changed, not recently, more than 10 years. And I think in centers in Malaysia, which first embarked on this whole approach, it's been at least more than 5 years that it is standard of care for these patients to get neoadjuvant therapy prior to surgery. When we are an oncologist, our nirvana is pathological complete response. So if we have a patient in front of us today who achieves PET-CR, that is, I think, the most fulfilling thing that will happen that day, because we know these are the patients who will achieve likelihood of a long-term survival. So it's like surgeons getting clear margin, good outcome, going home. For us, it's pathological complete response. And who benefits from neoadjuvant early breast cancer patients, we will look at that. And we'll talk a little bit about setting up neoadjuvant treatment services where you work. So why neoadjuvant therapy when the patient can actually be operated upfront? In the past, it was to try to make inoperable patients operable. We are trying to increase resectability. Yes, we want to conserve the breast as much as possible. As much as the surgeon wants to conserve the breast, the oncologist also wants to conserve the breast. We want to de-escalate axillary surgery. I believe the next 2 days is going to be a lot of discussion on sentinels versus axillary dissections versus neoadjuvant followed by de-escalated axillary surgery. So I'll leave that for that. We want to reduce the need for revision for residual tumors. So if a patient goes in for a surgery and ends up needing to go in for another surgery, I believe everyone in this room agrees that that is the failure of the surgeon, correct? Meaning no proper preoperative assessment, no proper judgment, patient had to end up going in for second surgery for whatever reason. Next, we want to improve survival as much as possible. We want to assess treatment response. So if you have a patient with triple negative who responds very well to chemo, it tells a lot about their prognosis. It tells a lot about their future outcome. It gives us time for prognostication as well as for mutation testing, genetics. So if you have triple negative, if you do BRCA, when the patient goes for surgery after 6 cycles, it has to be hopefully a prophylactic bilateral mastectomy. It has been discussed. One surgery, everything is sorted if the genetic testing is done in a timely manner. So by having the chemotherapy for 4 to 6 cycles, it gives us almost 4.5 months to sort all this. In a very practical way, it gives us time to also sort out finances, because very often the drugs may not be readily accessible for patients. So pathological complete response, the nirvana in oncology, triple negative breast cancer patients are here. The HER2 enriched patients are over here with the highest PCR rates. So in general, we see a triple negative breast cancer patient, 40% of them will achieve a PET-CR with the same chemotherapy that almost every oncology center in KKM is giving, anthracyclines and taxane-based chemotherapy. The drugs are readily available. All we want is to sequence it prior to surgery rather than after surgery. We know that the luminal A's are the least likely to achieve a PET-CR, and that's why in the current standard of care, if the patient is hormone positive, neoadjuvant chemo is only given for patients with inoperable disease or borderline resectable or need to conserve the breast, to try to de-escalate. But we are not looking at PET-CR in these patients. So when we talk about the endpoint of neoadjuvant treatment, which is PCR, you will notice here the triple negative breast cancer patients being the ones who achieve the biggest difference in achieving PET-CR rates, and followed very closely by the HER2 positive patients. We'll see how some drugs make a bigger difference than others in this subgroup of patients. You will notice here in the luminal A, the graphs are overlapping, meaning there's not much difference in PCR rates in the hormone positive patients. The luminal B, the separation that you see are likely the patients who are HER2 positive and also hormone positive. So when we look at meta-analysis, I know oncologists like to show a lot of graphs. I'm going to minimize the graphs and just summarize it by saying that meta-analysis of more than 12,000 patients have actually clearly shown if a patient achieves a pathological complete response in terms of their survival, their graphs are almost a flat line and they're right on top. Meaning at 5 years, more than 90% of these patients are actually alive. So if we give that opportunity to the patient to achieve a PET-CR before by giving neoadjuvant and going into surgery, automatically these patients' graph is elevated, and these are our long-term survivors. So these are our long-term follow-up patients who are still coming for follow-up after 7 years of having breast cancer. So achieving PCR is associated with good long-term outcomes, which is very, very clearly proven. Progression-free survival is clearly better. And we're going to talk about who are the early breast cancer patients who benefit from neoadjuvant therapy. So if we look at multiple guidelines, these are all very, very old guidelines, nothing new. Standard of care would be triple negative HER2 positive tumors, which are T1B and above. So these are really small tumors. We say arbitrarily 2 centimeters and above, or primary tumors smaller than 2 centimeters but axillary nodes which are positive, whichever of those. So this is actually a large group of patients who are triple negative, HER2 positive, 2 centimeters and above, or axillary nodes which are positive. The ESMO guidelines say the exact same thing. The St. Gallen says the exact same thing. The NCCN says the exact same thing. And if you want to look at something of a more of a local flavor, it will be our Malaysian third edition of the CPG guidelines, which have recommended HER2 positive tumors, acknowledging the increased PCR response, suggesting the usage of anti-doublet HER2s. I think the wording would be mandatory to explore because it's already in the formulary now. I know when the third edition came out, neoadjuvant trastuzumab was not in the formulary yet, but it's already in the formulary now. So at least offering a single neoadjuvant trastuzumab would be standard of care. A little bit about triple negative breast cancer, an extremely chemo-sensitive subset of patients. 35% or 45% will achieve a PET-CR, but we know that not every triple negative breast cancer patient is going to respond to chemo. I'm sure you've seen patients who progress well on chemotherapy despite everything being done. And that is again because of molecular subtyping. We know that triple negative breast cancer is not entity. So in oncology, it's getting more and more complex by the day because subtyping, NGS, genetics, everything comes into play. And we know that with all these subtypes of triple negative breast cancers, so you can have a basal-like, you can have a mesenchymal-like, you can have an immune modulatory-like, you can have an androgen-derived subtype. Basically, the response all depends on your molecular subtyping. So for patients, these are all not standard of subtyping triple negative, but the point to note is whereby outcomes are different and responses are different, but the majority will respond. So if we talk about what do we give for these triple negative breast cancer patients, it's the exact same anthracycline, taxane-based chemotherapy, FEC3, doxy3 is very standard. In KKM, we tend to standardize because we have, at least in HKL, 11 hospitals which are giving chemotherapy with no oncologists or oncology-trained personnel in the whole facility. So we standardize, we keep it simple, nothing too special, because otherwise overdoses, underdoses, wrong drug, a lot of things will go haywire. In the oncology centers, we are a little bit more creative, we are a little bit more dreading, but not in centers where there's no in-house oncologists. The keynote 522, very briefly, addition of immunotherapies. So nowadays, the standard of care is giving pembrolizumab. So some of you may have heard of this drug. It's expensive, but it works. It does wonders in the sense of, if it is pure chemotherapy, which is taxane anthracycline, which is 30 to 40% PCR rates, when we give pembrolizumab in combination with the exact same chemotherapy, we are now increasing the PCR rates to 60%, meaning if it's pure anthracycline taxane, 1/3 of our patients will achieve PCR. If we give them pembrolizumab, 2/3 of our patients will achieve PCR. So that's the difference. Pembrolizumab is 17,000 per cycle, buy one, free one, 3 cycles. So I know it's expensive, but there are patients who have the means, and hence discussing or offering it would be standard of care. We're going to talk a little bit about neoadjuvant anti-HER2 therapies. We're going to talk about trastuzumab, good old drug which came on more than 20 years ago. I think most of you are working in facilities where trastuzumab is standard of care. We're going to talk about pertuzumab, which is also being practiced in a lot of centers, and how it actually changes outcome. So in the HERA trial, we saw that adjuvant trastuzumab improves outcomes in the long run. So in the past, we know that patients who had adjuvant trastuzumab have better survival. And we know that their PCR rates are far better. So if you just give simple single agent Herceptin or trastuzumab biosimilar, whichever, you would increase PET-CR rates to 30 to 40% compared to 20% alone in chemo. So it's all about the figures and a rough estimate. So if the patient says how much benefit I'm going to get from this drug if I get it before surgery, if it is a HER2 positive patient with single agent trastuzumab, 30 to 40% PET-CR, meaning 4 out of 10 patients will achieve a PET-CR with single agent trastuzumab alone. Neoadjuvant trastuzumab is already in the KKM formulary, so the adjuvant cycles are now brought forward in the neoadjuvant setting. Majority of our patients will get neoadjuvant trastuzumab, at least 3 cycles prior to going into surgery. So it's 11% improvement in overall survival. In oncology, single digit, more than 5% overall survival is landmark study. So that's the kind of threshold and the kind of baseline that we are looking at. 11% oncology overall survival and difference you don't get with a lot of drugs in oncology. We're not very few drugs in oncology. So anyway, from a surgeon's perspective, trastuzumab improves breast conservation rates, it improves overall survival and long-term outcome. But in this day and age, it's no longer single agent trastuzumab alone. It is now doublet pertuzumab with trastuzumab. Why is it that pertuzumab and trastuzumab is better? Is why we're going to look into this later. So the Neosphere looked at different combinations: trastuzumab with chemo alone, pertuzumab with trastuzumab with chemo, trying to omit the chemotherapy and just giving the anti-HER2s and seeing whether that works. As we all know, there are many, many patients who don't want chemotherapy, but they want the targeted therapy. And of course, pertuzumab alone with chemo. So what we see from here is that if you're going to get 20% of your patients achieving PET-CR with trastuzumab alone, if you give them pertuzumab with trastuzumab, you're getting 45% of patients achieving a PET-CR. So that is almost doubling of PET-CR rates with 2 drugs compared to 1. And we have got long-term outcomes of 5 years and even 10 years outcome now, showing us clear difference in survival. And in the Trifina study, we are looking at the different combinations of regimes. So I'm just going to zoom in on the most common regime that we use in most centers, FEC3, docetaxel with pertuzumab, trastuzumab. You can actually give 6 cycles of pertuzumab, trastuzumab as well. In most private centers, that is standard of care, where cost is not a concern. But I think in our government facility, weighing outcome, costs, and all that, the second arm B would be the most palatable for most patients because majority of our patients are actually not paying for any of their drugs. It's all alternative funding under Magna, Zakat, welfare, maybe. And if you give these patients just 2 or 3 cycles of doublet, we will see how PET-CR is all in the range of 50 to 65% of patients. And I think our HKL data is very consistent. Our surgeons are here as well. More than 2/3 of our patients who got doublets will achieve PET-CR. And I think now after so many years of doing, we are seeing increasing numbers of patients who are coming for follow-ups with no recurrence. And I think that's one of the most fulfilling things that has happened in the last decade. So event-free survival in these patients are very, very clearly better. So nowadays, the treatment paradigm for HER2 positive early breast cancer, so these are operable patients. We're not talking about metastatic patients here. If your tumor is more than 2 centimeters, your tumor is node positive, standard of care is pertuzumab with trastuzumab. Patients go in for surgery. If they achieve a PET-CR and they are low risk, they may get away with adjuvant trastuzumab alone. But if the patients have a resistant disease and they are not that 60% of patients who achieve PET-CR, these are patients with more aggressive disease, residual disease patients are supposed to get adjuvant Ketsana or PM1. So there's another drug that's basically the oncologist problem. For patients who have got node positive or hormone negative patients, low risk disease, T1N0. So it is only in the T1N0 subgroup of HER2 positive patients that surgery comes upfront, followed by adjuvant trastuzumab. In patients who are node positive, if they happen to go for surgery first, which is still practiced in a lot of places, they would likely need doublet anti-HER2 therapy, which is far more expensive and outcomes are still not as good compared to just even 2 or 3 cycles prior to going in for surgery. So I'm going to just spend the last 2 minutes on setting up new adjuvant treatment services for early breast cancer. I'm not sure how many of you are in facilities whereby early breast cancers and in HER2 positives and triple negatives are automatically referred for neoadjuvant therapy. It can be a little bit of a work process initially to establish the collaboration between multiple disciplines, but it's extremely doable and can be done. So again, we need the joint effort between surgeons, pathologists, radiologists, oncologists, and I believe the only way it can happen is through MDTs. So we have been trying very hard to have multidisciplinary team meetings for all oncology patients. So if we work in overseas centers where certain qualities are in place, every oncology patient must be seen in an MDT before anybody touches the patient. Not the oncologist, not the surgeon, not the physiotherapist, not the social worker, nobody. Everybody sees the patient in an MDT, not just for breast cancers, any cancers for that matter, lymphomas, head and neck cancers, you name it. It's all about MDTs, and only then above average standard of care can be achieved and a good discussion can be seen. We want to establish the workflow, having ER/PR HER2 on initial biopsy. So I'm glad to say, I think nowadays in KKM centers, these are very much standard. It was a struggle initially, but I think now almost all centers have ER/PR HER2 on initial biopsy. So if you don't have ER/PR HER2 on initial biopsy, this whole talk has no meaning because we don't know what is the subtyping. Unfortunately, we still see patients in private centers where ER/PR HER2 is not that on initial biopsy. So hopefully through forums and teaching sessions like this, that awareness that ER/PR HER2 is an initial biopsy will be well established and everybody is aware. I think the current challenge that we face is actually mostly in private, not so much government, where surgery has been done not knowing ER/PR HER2. I'm sure all of you are aware of this practice. Yeah. So identifying suitable tumors, meaning the 2 cm tumors of the node positive patients. Who are the suitable patients for this approach? We want early biopsy reporting, early staging, early oncology level. I know all of you in this room are saying what's early in KKM. But I think it can be done. through networking with our pathologists, with our radiologists. So when there's MDTs in place, a lot of these things will fall into place. We want reporting within this week. We want staging to be done within this week. We want the clips to be inserted within this week, and we want the patients to be in oncology on the daycare cover this week, and we want surgery to be done by this week. So all these things make a very big difference when it comes to oncology. Timeline is extremely important. I'm sure all of us agree, right? When there is delay, your prognosis naturally will drop. It is a known fact, right? And hence, marking the tumors are extremely important because these are early breast cancer patients. Tumors are small. HER2 positive and triple negative breast cancer patients sometimes have complete response clinically, don't know where the tumor is, even don't know where the tumor bed is, because we do expect these patients will have tumors which really shrink very well, even after the first cycle sometimes. So there's some differences in opinion on the timing of putting in the clips. Is it upfront? If your tumor is 5 centimeters, do you put the clip on the first day that the patient appeared in the clinic? Would you wait for it to shrink down a little bit before we put the clip in? So I believe that there is some differences in opinion among practitioners, radiologists versus surgeons, the method of clip insertion, how they're assessing the tumors every cycle. So I think it depends on the center where you work, what is in agreement between the surgeons, the radiologists, and pathologists. As long as it's done and the tumor is not missed, so that the patient's breast is conserved. And of course, if it's marked, when the HPE is reported, pathologists are usually very happy when the clip is there. Otherwise, they are like scrambling all over looking for where is this tumor. So you might miss microscopic residual disease because of not knowing where the tumor bed was and that sort of thing. So planning the date of surgery and adjuvant treatment and assessing response, how often the ultrasound should be done before the surgery, all those things are, I think, institutional. I don't think there's very clear-cut mandatory guidelines on this, but it makes a big difference if everyone in the MDT is in agreement and it's agreed upon. So my take-home message for today is neoadjuvant treatment for triple negative and HER2 positive early breast cancers for tumors which are more than 2 cm or node positive, in my opinion, is an ethical obligation. In oncology, if we have patients who were not offered neoadjuvant therapy prior to surgery, it can be deemed as mismanagement, potentially medical, legal, and something which has huge implications, which I think in our field, we will never able to do any damage control after that. Because once the patients are operated up front, when they come to us, we usually follow them up until the patient passes on. So that losing that opportunity cannot be compensated in any way till the end of that patient's journey. So achieving pathological complete response translates to a significant survival difference. And with that, I hope I managed to brainwash. Thank you.
Thank you very much, Dr. Vaish. It's very concise, precise, very short and sweet. Okay, not so much graph and not so much statistics. That's what the surgeons want. Thank you very much. Can I open the floor for any question? And for your information, in each table of you got one barcode. Can you just scan the barcode so that you can just write whatever question you want to ask the speakers? Or you can just may raise out your hand to ask the question, or you may just write through the scanning with the barcode. Yeah. Or anybody wants to share any experience using dual blockade from each center? Yes. Ms. Leong.
Leong here from IJB. Yeah, that's what I asked. Is the anti-HER2 targeted therapy, is it available in all KKM facilities?
Okay, so trastuzumab has been in the formulary for more than 10 years in the adjuvant setting. The neoadjuvant indication was approved I think a year or two ago. So trastuzumab neoadjuvant is standard of care and all available in the formulary and applicable. Pertuzumab in the neoadjuvant setting is not in the formulary. So patients who are going to be offered pertuzumab, which I think in HKR is 100% of patients, everybody will be offered a tablet. If they have funding, it's self-purchase, but it needs UKK. I would say 80% of our patients can't pay for it, but they will all be referred to welfare, zakat, or some form of alternative funding, aiming to get the drugs in latest by cycle 5.
All trastuzumab is available in all KKM
oncology centers. So the drugs, as in trastuzumab, for at least for HKR, because it covers 6 states, trastuzumab is sent via ambulance to Temelloh, Tanjung, Terbintan, Kuantan, Ipoh, Kota Baru, So the drugs actually are sent literally physically because all of these centers don't have budget for drugs. So it all comes under oncology, HKM, and then it's done, the lab will be sent out.
The patient really can't afford to pay for it. The private center can always refer to the TNBC.
No, of course. So if a private patient does pertuzumab Herceptin in private, minimum cost will be about 19,000 per cycle.
I can cancel this one first.
I
can cancel first.
You only pay for
Yes.
everything else is eliminated. So you will end up with
This one? Okay, this one.
Can.
Okay.
Project is.
Is it just the drug?
Already breast cancer, breast cancer. I think it's better to be more assessing, but be very careful about assessing breast cancer. So you know, chemo alone is about 1 to 5 patients.
That the next.
Okay,
Thank you so much.
So basically, the anti-HER2 drugs work in addition to the chemo. So if some patients say, I don't want to use my hair, but I want the anti-HER2 drugs, that patient's response is going to be lower than the cure. So the chemo is still the backbone, the anti-HER2 drugs pop up that response, but you cannot be able to do that. So I think in terms of funding, in terms of, because the biggest barrier is funding, awareness is not a topic on its own, but funding is the other area. So I think depending on the center where you work, exploring access, telling patients on the potential benefits, because these are therapy, good outcomes that they really get. It's not my so in oncology, a lot of things are like, you see graphs which need a magnifying glass to see whether they're actually saturated. So this is not one of those. So in terms of if you want to really do something for the benefit of our breast cancer patients, this is the field where the biggest benefit has happened in the last 10 years. So even if you see the internet is bigger, at least if the internet is already started out here for some years.
Any more questions? Oh, okay. We have three questions. One is Dr. Vaish, thanks for the sharing. May I ask on biomarker clipping? How can we help and refer patients?
Yeah, so markers are $400 if you have a second of so
$400 per clip or per clip?
Yeah, it's about that. Ours is about that. So I think actually we are good at because our ability language is not the kind of somewhere so we have to I think the center is so it's about working on under hospital which is the best because most of our patients can afford anyway. But for patients who cannot afford or sometimes we run out of budget for the keep. So what it means all under Magna. So all is under Magna. And we've actually established a flow with our welfare department whereby we start with the petty cash. Petty cash means for drugs for items which are less than 1,200. The welfare officer can approve it on their own, doesn't have to go to Magna either. So like the healthy obviously said so our kids, whenever they go to technically are hospital in the last. So that's how we do it.
Can I know here, any hospital who doesn't have any clip? Oh, so you that wondering. Any other hospital who has not used any clips before you and you will give that?
So does that mean if the patients have to pay,
Yeah.
it also means the hospital doesn't have to pay? Okay.
No.
So that question can be interpreted. No access, that means cannot die.
No, I mean that any hospital who has not yet used this kind of procedure. Because all the neoadjuvant chemo, before you give, particularly when you use double blockage like this, your response rate is very good. So means that after 2 cycles, it will complete response already. That's my experience. So this is how the need for using the clip before you give this kind of neoadjuvant chemotherapy. Okay, question number 2. GPA.
The breast is also very important. It is a breast considering surgery for patients flexibly after. Because frankly, there is no radiation. There's a positivity of the breast concern. So the whole chest wall of the breast is radiated, but if you don't know where the primary tumor was, there's no way that you can boost that tumor. So to the kids, yeah, so I know the places that we get rescued to the get. So this will be so pleasant. But other than that, what we usually do is we have to ask, can you sit on my hand? Because if you don't know where the tumor was before, you can't actually increase the dose of radiation to the tumor bed. So very often it's very random. I just like, okay, can you go? Yeah, look at another rat. Yeah, look at the other song here, I made it all to be burned. So if anyone has extra money, who has budget to invest or something, and who has to do one of those ideas.
Right, okay, we'll go to the next question. Now, GPA now approves 6 months of consultation only nowadays. Is that correct in other hospitals?
So currently, all Indian centers are only doing 6 months of adjuvant. It's based on the personified trial. The institution is not superiority. So it's not superiority, but it's not inferiority. Frankly, from a very practical point of view, if our patients have a high risk disease like NP disease and 2, 3, 4, we actually push on the receptors we dominate something, aiming by that. But under hospital, it is 6 months, and I wouldn't be wrong to say it is a lot to also be unlimited resources. But if you want to ask whether their health is supportive, yes, they are. Non-inferiority trials are available. So if we give 6 months, we can do 200 patients. If we give 1 year, we give 100 patients. Meaning, a lot of patients will not need any hospital.
Next is, how many cycles of anti-HER2 ideally for a patient should patient receive before surgery? Some only receive 1 cycle, some receive more, the rest continue as adjuvant.
So anti-HER2s, if we give them ideally at least a minimum of 3 cycles will be good. We saw the graphs just now, so even if you give doublet, 3 cycles versus 6 cycles is a difference of 5 to 10%. So 6 cycles is important. That is a marginal difference compared to the 20% which has now become 60%. So you will achieve 50 to 60% with 3 cycles. So in oncology, it's a lot of figures and estimates. So the difference is I'm going to do my KWSC dot to the consumer.
I think
Okay.
the first one.
All right. Okay, Dr. Vaish, if a HER2 positive patient had already completed NACT positive without anti-HER2, can he proceed with surgery or patient still need
Not the best, but so the faster the patient is exposed to the anti-HER2 drugs, the better for the patient for a long time. So we should start off with CA.
So this is using a single agent. Okay, thanks for sharing. May I ask, how would you advise center with funding challenge on biomarker?
Oh, this one
treatment?
done. This
How
one done.
can we have
This one. The first one.
done?
Yeah.
Which one?
Oh.
How is Ki-67 useful in your practice?
So Ki-67's benefits, mainly
Oh, how much like how much is
if you are triple negative or HER2 positive, your Ki-67 has no benefit. You are high risk no matter what. Even if you are 0.5 centimeter HER2 positive, you are high risk. So for adjuvant, you know, 0.5 centimeter triple negative is not viable. Or 0.5 centimeter HER2 positive, everybody is still already. So you doesn't have one high, your high is high. But if you are luminal A, you need your positive, or you are luminal B, that HER2 negative. So luminal B's can be your positive, HER2 positive, or your positive, HER2 negative. So that's where the Ki-67 comes in very. So if your luminal A and your Ki-67 is less than 10%, you are looking for concentrations, not evidence. Even though you are not positive,
This one
your
done.
Ki-67 is low, the benefit of chemo is very low. So we are trying to convince our pathologists that if they do Ki-67 for us, we can save a lot of patients. Only to
Yeah,
that.
this one.
But now because we don't know cancer,
Primary, high.
it's like a goes up over the day, and of course, we should die.
This one done.
So in Kenya, we did organized by.
Not yet.
Oh, this one.
But
Yes.
instead of getting for late time.
Oh.
So we managed to get that. All the other things was about the Ki-67, very empty.
So in Kenya, all the grandparents to have time to be done.
这个也是还没有知道，没有，还没有办法去了解。
No additional costing. Just that we have some issues with such because it's I got the
Is how much that additional money will be added on?
not much additional money for moving forward. That's happening.
Moving forward, but no possibility.
3 more questions. Hi, this side.
Okay. I think my question is related to that question where I had one question,
Oh, okay.
I'm just going to rephrase that question, but we know that it is a either T2 or N1 HER2 positive breast cancer cases why not? Whereas because the result says that it can put FCR. So I mean, simple logic would seem smaller region and like people would get more FCR, but why would we exercise that?
Yeah, so the study that looked at the evidence of neoadjuvant therapy were mainly cause and the early responsive T1 patients did just as well with upper because their systemic max is not as high. Because already then. So when we give early breast cancer patients neoadjuvant, it's not only the downsizing and the vaccine of the gene, but also eliminating the microscopic metastasis study. So in the early one and below, that microscopic mass risk is not as high. So because the trials have been done with two animals,
All right.
but you may be right, another patient may also get
Okay.
this as well, but in the guidelines, it is different. But I know there are sometimes patients referred with T1 and perhaps we counsel patients and say, yes, you will like benefit, but you don't fall in the trial inclusion criteria, and some patients want it, but not as a
Okay, we still have 5 minutes. So I think one more for which one? The last one. The first one. Okay, if HER2 positive patient had already completed, that one done.
The second one.
Second one, how many cycle of HER2 ideally patient should receive before surgery? Done.
some rates are 8, but I would say minimum 3 to get a good outcome. Some of
3,
them really get good outcome. Even 2 is okay, 1
Okay.
is another.
Okay.
So I don't know whether it's more. Maybe it's progress.
Yeah. Yeah. So this is a view from the oncologist. Dua pun okay.
No, I mean,
3 is good.
then
2.
most of the patients will get
Uh,
something. Some patients, their weight funds 6.
Six,
Good
huh?
for 6.
Okay.
5 patients 6.
Uh,
Validation.
Yeah.
7, 8, or development.
Okay. Okay. Let's say you have given 3 complete response. You did a surgery, and then post surgery, do you still have to give
Yes.
another?
So if there were patients who had neoadjuvant doublet, we still must get the adjuvant. If they are not positive, they are supposed to get doublet and adjuvant. So in reality, the majority of our patients will get
Single agent. That's right. Okay, I think my last question, for those who had neoadjuvant chemo upon completion operation within 4 to 6 weeks, if the operation date is way too late, does continuation of Herceptin play a role?
So for PET and usually we don't push on more than 6 cycles. But definitely keeping to the cycles of the anti-HER2 is very, very important. So what we have done in Israel is we tell the DKMOs, doesn't matter when is the surgery, keep PCA 3 weeks, because frankly from our point of view, you can have Herceptin or trastuzumab yesterday and go in for surgery today. But I know sometimes surgeons are a bit concerned about waiting for surgery today. So regulations are on adjuvant and HER2 alone. The guidelines does not even require a FDC. We don't expect neutropenia. We don't expect poor bone healing. We don't expect any much of a complication. So our trastuzumab and trastuzumab patients only get the test, which is like FDC, RPL, whatever, 3 months once. So when they come, they just have they jump on the couch, they have the entire everything. So we really don't expect any form of neutropenia, sepsis, rates, whatever. Wound healing has not been shown to be pure with all the patients who get trastuzumab. So the guidelines say if we delay the anti-HER2 therapy by more than 6 weeks, the patient has to be loaded again, meaning double dose has to be given again, which is very expensive. So we try to keep the 3 weeks, and then once we know the date, also sometimes we don't know the date of surgery. Once we know the date of surgery, because we can't present it, I will give it, and we just proceed. So yesterday, no issues, and we just keep on pushing the 3 weeks. So the adjuvant might even come as new adjuvant, just continue. But anything more than 6 weeks, we have to go back because the serum levels are dropped or come back. So we try to do that.
All right. Okay. Thank you very much for all the questions as well as the answers. And lastly, I would like to say thank you again to Dr. Vaish who come all the way from KL. And KL, not from Kota Baru. And then I think we should thank as well to Rosh who has bring up the issue as well as Dr. Vaish in the usual manner. Thank you very much.
Thank you, Dr. Vaish, for very engaging talk. So since we've been running a little bit of time, next is with great pleasure and anticipation that I extend my warm welcome to Prof. Mawada, an esteemed ENT from UKM, who joined us today to share her expertise on the topic of intraoperative nerve injury.
Is that okay? If it's too short, you will be presenting here. Assalamualaikum warahmatullahi wabarakatuh to everyone. So I'm Mawada Azman. I'm an ENT surgeon. So today I will be sharing about intraoperative interventional nerve injuries.